hyperandrogenism is a major presentation for us in terms of endocrinology practice. So 50% of entire androgen in the body comes from the ovary, which is the major production of androstenedione, and 50% comes from the adrenal, and adrenal produces both DHEAS as well as androstenedione. Now, these are all precursors. They have to be converted to testosterone. So if you want to now look at, Dr. Fauziya, whether this testosterone production is coming from the adrenal or the ovaries, which test will tell you that this is coming from the adrenals? So I have said androstenedione is produced via both ovaries and adrenals, and DHEAS comes mainly from the adrenals. So if you look at DHEAS, that will be a marker of adrenal androgen production. So this is one test you will say, okay, DHEAS is normal. I'm not going to bother about CAH. This will be something to look at. Now, as I said, andro also comes from there, and this all will then be converted in the periphery using the 17-beta-HSD into testosterone. So if somebody is obese, you will have more fat. More fat means more 17-beta-HSD, means more androgen. So peripheral hyperandrogenism is also a well-established term. So I said adrenal, ovary, but 7% cases they have got normal adrenal, normal ovary, yet they have hyperandrogenism. That is the peripheral hyperandrogenism associated with obesity. Now, what are the common hormones which metabolize steroids present in the fat? So I've talked about 17-beta-HSD. What else is there? Aromatase is there. What else? No, I'm talking about the enzymes which are there. So 17-beta-HSD, aromatase, 11-beta-HSD, and ANG2 synthesis also, all that mechanism is there. So if you got more fat, you will have more amount of androgens in females, more amount of estrogen in males because aromatase is there, more production of ANG2, angiotensin 2, causing hypertension. And I discussed this 11-beta-HSD also, your cortisol goes up. So in a way, your cortisol Cushing's, pseudo-Cushing's like picture can happen. So just the fat is so important. And of course, you've got 1-alpha hydroxylase and all the other things as well. So they will cause huge changes in terms of metabolism, which is there. Now, ovarian androgen synthesis, we all know the same pathway. You need to synthesize androgens to synthesize estrogen. So same side chain cleavage, 3-beta-HSD, progesterone, from there, the theca cells. So this is a two-cell hypothesis. The theca cells, which are in the periphery, produce the androgen, and then they give this like a substrate to the granulosa cell. So theca cells have got 17 and 21, while granulosa cell has got aromatase. So from here, this aromatization happens. The theca cell is regulated via LH, which is equivalent to the Leydig cell. While the granulosa cell is regulated via FSH, this is more like a Sertoli cell. And from there, you have the estradiol production. Now, one common link we always talk about is obesity with hyperandrogenism. And the one major reason is insulin. So in obesity, you've got insulin resistance, your insulin levels go up. This insulin has got multiple effects on the ovary. How does insulin cause hyperandrogenism, Vibha?
Resistance, there will be less IGF-1 and there will be increase of IGF-1. So that's the insulin. There is a insulin resistance in the hepatic region, but this high insulin is a stimulating factor for the ovary to.
So this is a very important phenomena that you're talking about, is that there is a selective estrogen resistance. So there is a peripheral insulin resistance, but insulin sensitivity in the ovary is there. So this insulin is not working anywhere, but in the ovary, it is producing more. So insulin, what is going to do to ovary?
It causes production of more like this follicles.
It causes more ovarian stromal growth. So more stromal growth, more action of steroidogenic hormones. So you will have more androgens being produced. And from the periphery, because of this insulin resistance, you have got more level of free IGF-1. That would also cause ovarian growth. It will also cause fat deposition, where your 17-beta-HSD becomes more. So that's why obesity and insulin resistance causes hyperandrogenism through multiple mechanisms. IGF-1 also increases the ovarian size. So acromegaly is a known association or a known cause of hyperandrogenism. So when you diagnose PCOS, you have to exclude causes. You talk about hypothyroidism, hyperprolactinemia, acromegaly, Cushing's, all these things have to be considered there. Now, FSH is a major regulator of the granulosa cell, and we all know that TSH and FSH have overlap. If you have got a high TSH state, you will have large ovarian cyst, you will have hypothyroidism causing a von Wieck-Grumbach picture, hypothyroidism, short stature, precocious puberty. That will be the phenomena. Now, very importantly, when you talk about androgens, they have a systemic effect, but most importantly, the paracrine effect is very, very important. So androgens, what they do? So we all know, we discussed this earlier, that till the level of around primary follicles, you have got no role of any gonadotrophins. They keep developing by themselves. Then you have got the FSH, the LH, and this LH levels will cause luteinization and other processes will start happening. Now, what does androgen do? So what do you think is the effect of androgens on the ovarian environment?
Just small multiple cysts, increases the LH level, which again increases the multiple.
So androgen is causing more growth of the small follicles and it is inhibiting the growth of the dominant follicle. So it is like an anarchic state. You've got some rebel, some naxalite or something like that is there. So it is causing disruption. What it will do? It will say, okay, I don't want a very prominent leader to emerge. I want more chaos. So I'm happy in the chaos. So it is causing chaos there. It is saying, okay, you also grow, you also grow. So multiple small follicles keep growing. Now these small follicles will again produce testosterone. So your testosterone keeps rising. And it is not going to form a dominant follicle. Dominant follicle is going to do, it will destroy all the other follicles. It will produce a lot of estrogen. So it will be good for the ovary. But it is causing a sort of a chaos there. And that is why this causes a multiple small cyst which will be formed. And the peripheral multiple small cyst, this is known as the PCO appearance. So PCO appearance is not the cause of hyperandrogenism. It is the effect of hyperandrogenism. You get the point? Anybody with hyperandrogenism, you give outside androgens, you have CAH, you have got hyperprolactinemia. Any condition which causes hyperandrogenism will cause a PCO-like appearance. So PCO-like appearance is the least important diagnostic criteria of PCOS, which is a misnomer, I would say. You should call it FOH will be a much better word, functional ovarian hyperandrogenism, because PCOS, you assume that polycystic ovary is the main. It's the effect, not the cause. So androgens are bad for the ovary. They have got very, very number of small chaotic follicles, no structured estrogen synthesis, no dominant follicle, and that's why you will have a bad response from that perspective. So androgens are going to say, okay, small follicles, you grow more. They are going to inhibit the dominant follicle, and this is the problem. Now, this is the point I was discussing, and this is very, very important because how hyperinsulinism causes hyperandrogenism. So basically what you're looking at, if your insulin levels are high, your IGF-BP level becomes low, free IGF becomes more. Second, insulin also inhibits SHBG. If your SHBG is on the lower side, what you're looking at, your free androgens will also go up. So free IGF-1 is high, free androgen is high, and both of them will have a issue from that regards. Now, there is a preserved ovarian sensitivity. A lot of people say if you have insulin resistance, how does ovary produce? Because ovarian responsiveness is preserved. So this is going to cause theca cell proliferation and in extreme forms. So if you have seen patients who have got very severe insulin resistance, like insulin resistance type A, or autoimmune there, you may have very, very large ovaries, increased theca size, and they will be virilized. They will look like an ovarian carcinoma and large ovaries. What is this condition known as? Yes. So if you have uncontrolled hyperandrogenism for a long time, the theca cells will become so huge that testosterone will go to 400, 500. They will look like males. They will have more muscularity. They will have voice change. They will have clitoromegaly. So all those things will happen. This is hyperthecosis, which is one of the mechanism through insulin action. Now, insulin also has an impact on the adrenals. where it is going to work out, it is going to also have an impact on the hypothalamus as well as the adipocyte. So there are multiple effects, but primary effect is in the ovarian regards. So now what I'm trying to say is that if you improve this insulin resistance using metformin, using lifestyle, whatever mechanism, it will be beneficial. So insulin resistance is a primary, it's the most important pathophysiological cause of polycystic ovarian syndrome. So if you want to prevent PCOS, prevent insulin resistance. Now, once you go into this vicious cycle, the problem increases further. If you have got high androstenedione levels, it is going to cause reduction in adiponectin. And this is going to cause more insulin resistance. So what I'm trying to say is that if you allow hyperandrogenism to continue, you will have a sort of a vicious cycle. The levels will keep on increasing. Now, what are the amplifying mechanisms of hyperandrogenism? High androgen causing more high androgens. So we have talked few. You tell me now. One I have told now here is that if you have hyperandrogenism, you will have insulin resistance. So it will cause worsening. Second,
high androgen will inhibit the progesterone inhibitory effect of LH.
Yes. So more LH, more production. Good. Next. More small follicles will come up and insulin resistance. So basically, you don't want the androgen levels to be high for a long time. So a lot of people say, okay, when you say PCOS is unexplained, persistent, ovarian hyperandrogenism, you want 2 years to wait before you make the diagnosis of PCOS. Why do we treat in that 2 years? I would be treating in those 2 years if you have got significant hyperandrogenism, because I do not want to have the bad effects of androgens on the ovaries. If you talk all in nutshell, high androgen is going to keep on having this cycle. So I have to break this cycle. So that is why waiting and watching is not a good phenomenon. If you have established hyperandrogenism, if you have established that there is significant hyperandrogenism, treat, don't wait. And you can always stop later. That will be a big message, because it's hyperandrogenism begets hyperandrogenism, and the whole process will keep on continuing from that regards. And as discussed, this whole insulin resistance process will be there. Now, already we have discussed that the same SHBG which controls the ovarian estrogen metabolism and transport also controls the testosterone. If you have hyperandrogenism, the SHBG levels will decrease. So what will be the impact of hyperandrogenism in the estimation of testosterone levels? Will you underestimate testosterone using total or overestimate? So SHBG is low, your free testosterone is high. So what it means is that, okay, if you measure total testo, you will find the level may be normal. So it has got a lower sensitivity to diagnose hyperandrogenism as against a free testosterone. What I am saying in other words is that if you have somebody who has got hyperandrogenism, you may have a normal level of total testosterone, while free testosterone will be high. This is the mechanism. So what people have done, they have decreased the cutoff. So the cutoff for testosterone, earlier people used to say 80 nanogram per dl. Then they talked about 60 nanogram per dl. Then now they say 55 nanogram per dl for the adolescent criteria. So adolescent hyperandrogenism cutoffs are lower because of this whole concept that this is going to be affected by SHBG. Now, can you use this for treatment perspective? We already discussed about this SHBG phenomenon.
When we get extra progesterone, then SHBG levels will rise and we will get to the
Yes, so if you, this is a very important therapeutic modulation. You want to increase SHBG, give estrogen, and your testosterone levels will come down. That will be the mechanism, and free testosterone acts there from that regard. And we know testosterone inhibits SHBG, and we've discussed about that. So to summarize, what androgens do to the ovary, they have got much more effect in terms of the bigger follicles, while the smaller follicles will keep on growing in that regards, and you've got this typical PCO appearance, which we already discussed. Now, what do they do in the pituitary? We know that progesterone comes from the Leydig cell equivalent, which is basically the theca cell, and it inhibits the LH production, and the estradiol and inhibin inhibit the FSH levels. Now, androgens decrease the progesterone inhibitory effect on LH. So if you have hyperandrogenism, what will happen to the LH levels, Vibha? So this all talk about high LH, LH-FSH ratio and all those things in hyperandrogenism. This is again the effect and not the cause of hyperandrogenism. It may further increase, but that's not the primary thing. So high LH-FSH ratio is not a diagnostic criteria for PCOS, as many people will think of. And we all know about how the pulse is. So what will happen with this? The pulse secretion will change. You've got more LH, less amount of FSH, which is going to happen in that perspective. Very importantly, if the fetus is exposed to high androgens, the inhibitory effect of progesterone on LH is permanently reset. So when I say fetus, we are talking about CAH as a classical example, or even aromatase deficiency. So if the fetus is exposed to high androgens, they will have reset of the axis. Their progesterone is never going to inhibit LH. Their LH will always be high. So these patients will continuously have hyperandrogenism from that perspective and regards, and that becomes important. Now, we already discussed that DHT is a major player as far as the hair growth is concerned, and most manifestations of hyperandrogenism are hair growth related. So DHT and estrogen are the opposing pictures. So retinoic acid, what will it do to the hair growth? It will increase and it will inhibit the effect of DHT. So that's why it's used as an acne treatment basically. And DHT in certain areas will cause more hair growth, like androgen dependent areas, like the chin area, the beard area, the chest, the abdomen, all those areas. And that is going to cause hyperandrogenism. In certain areas, it is going to cause more sebaceous production. So you will have more acne and you will have other manifestation. In other areas, it's going to cause hair fall. So you will have androgenic alopecia. So what is the typical androgenic alopecia pattern in females with PCOS? So when we talk about the male pattern, it is less likely. It's more like a Christmas tree. So it's like a zigzag. So they have a problem there. Males will more have a temporal pattern, which is there. Now, manifestations, cutaneous manifestations of hyperandrogenism are race specific. You need to understand that. So in different races, you will have different phenomena. So do you have any example, let's say in Indian setting?
They are more have like a criticism there.
So Mediterranean areas, Italy, Arabic areas, including India, you talk about Sindhi, Punjabi, these populations are more likely to have hyperandrogenism, mainly in terms of facial hyperandrogenism. While if you talk about the Northeast people from those areas, or even the Asian countries, they will not have hirsutism. This is because of the naturally also their hair growth is much less. They will come more with acne. And in our setting, we also see a lot of alopecia. A lot of patients come with that typical Christmas tree pattern alopecia, which is common. So all these manifestations can be features of hyperandrogenism, be it be it hirsutism, be it acne, which is refractory, be it alopecia, which is those phenomena, and one condition which is known as hidradenitis suppurativa, which is basically a tender, painful fat necrosis. So you have got axillary swellings, which will be very tender, and this is also a common